Welcome everyone to this new Greytalk. Today we have the privilege to have with us Dr. Daniel Lopez Acuña, public health physician specialized in health systems, migrants and refugees, health and humanitarian health action. The title of his Greytalk today is COVID-19, the Encore, Why Vaccination Still Matters. And of course, including the recording of this session, the very extended bio CV of Dr. Lopez Acuña, but just for the record, I will recall a few elements of his bio. Daniel Lopez Acuña, Dr. Lopez Acuña, has worked for more than 30 years for the World Health Organization in different management positions. He was Director of Health Action in Crisis Situations at WHO in Geneva. He was appointed advisor to the WHO Director General and supported the design and implementation of the WHO reform. He was appointed Director of Cooperation and Collaboration with the UN system countries, a position in which he participated in discussions on repositioning the UN system for the 2030 Sustainable Development Goals. Since he retired, he has been working as an independent consultant in the fields of epidemiology, public health, health systems, development, cooperation, migrant and refugees health, and humanitarian assistance. He's one of the most prolific and respected epidemiologists. He has coordinated the European projects on refugee health and health inequities. He has been a jury member of the Princess of Asturias Award for International Cooperation in its 2018, 2019, and 2020 editions. He has published several books and numerous articles in the field of public health. Dr. Lopez Acuña has been a steadfast voice for reasoning through the COVID-19 pandemic. His expert opinions and evidence-based insights have guided nations and communities during these challenging times. And of course, Dr. Lopez Acuña is now emphasizing once more the vital importance of vaccination. And just before moving on to the session, I just watch the newspapers in Spain, and this is what seems to be an unrelated event. Dr. Lopez Acuña just received an honorary distinction as from the Confraternity of Disarmament in Oviedo. And this is an angle that, frankly, I didn't know, even with my whole career in United Nations, is promoting peace and disarmament through cooking, if I understood correctly. Can you give, when you have the floor, Dr. Lopez Acuña, a few insights of this new distinction that you just received? And with this, I will give the floor to Manuela Tortora, who will lead the session and give us some kind of insights. So the floor is yours, Manuela, before giving it to our great speaker today, Dr. Lopez Acuña. Please.
Yes, thank you very much, Alejandro. Good afternoon, everybody. Good afternoon, Dr. Lopez Acuña. So maybe you would like immediately to reply to this collateral sort of issue before getting into the deep waters of the main topic today. And I hope you will have both news, good news on both topics. So please.
No, this was simply a distinction that I got on Saturday from a confraternity or confrérie of disarmament in Oviedo, and this has to do with a tradition that dates back to 1836, where through cooking and the sharing of food between two enemies of the same country that were fighting for the Queen Isabella and for the King Carlos, well, there was a ceasefire because of the cooking, and then annually this is celebrated, and well, the spirit is to see that the food can do the necessary to reduce the confrontation and abandon the rifles, the weapons, and the ammunitions. And well, in the same spirit, I worked many years in an initiative in WHO that was called Health as a Bridge for Peace. I've been saying, well, we should also make food and gastronomy a bridge to peace. And maybe you know that last year the Princess of Award was given in the category of reconciliation and peace to the famous chef in the US, but from Spain, from Asturias, Jose Andres, for this special program that he has developed of organizing chefs and cooks to provide meals in crisis situations, especially in earthquakes, in floods, in natural disasters, but also in conflict situations. He's also being involved in Ukraine, for instance. So I think some of the most critical needs that we face when we have a crisis situation is the desperate need of food. And well, all of this that I was involved in this recognition as an honorary awardee of this fraternity or co-fraternity was in favor of food for peace, let's say. Sorry for taking some minutes.
Excellent initiative, yes. And there is a UN book on food for peace that was published something like 8 years ago with recipes from all over the places and with the same idea, yes. So
good,
congratulations.
Good. Thank you.
So now you have the floor regarding, I hope, some good news, maybe regarding COVID pandemic vaccines and so on.
Okay, well, first of all, thank you very much for Grey Cells for inviting me for this talk. And also thank you to Alejandro, thank you to Manuela for the introductory remarks. I think this is the third time I'm with Grey Cells during the almost 4 years of the pandemic, in different moments and for different, I would say, for underscoring different aspects in each of the talks. But this time I want to insist on the message of not lowering the guard because the pandemic is not over, and on renewing our protection through the vaccines. But I will get into this. I will project slides now. Let me see if exactly. You can see the slides, no? Yeah, okay. So the talk has been titled COVID-19, Why Vaccination Still Matters. And this, I think, condenses the message, but I think it's important to elaborate a bit to understand what are we talking about. Now, let me see if I can make it move because I'm having a little bit of trouble in doing it. In advancing the slides. I don't know why, but let me share again. Sorry for that, but sometimes the system doesn't operate as one wants. Let's see. Okay. Now, yes. Okay. Well, first of all, let me say that there has been a COVID surge after the summer. So these are not so good news in a sense. At the end of the summer, we have faced a COVID surge in the world, not in one country or the other, but this has not received sufficient attention by the health authorities and by the political authorities and by the media and the public. WHO reported a global 38% increase in COVID-19 cases in the month of August. So I think this is not minor, and this we should take seriously. This represents more than 1.4 million new cases from July 31st to August 27th, only in that period. And considerably, and certainly this is an underestimated figure, because in many countries, more in some countries than in others, the diagnostic tests are not being performed to confirm either symptomatic or asymptomatic cases of the diseases. They are not being carried out to the same extent as in other phases of the pandemic. But even with the sentinel surveillance, with the surveillance in some segments of the population, with the information systems that register cases in the primary healthcare and in hospitals, we have seen in August, in between July and August, and then also September, an increase in the cases of COVID. Not as severe as we saw at the beginning, fortunately, and thanks to the protection that we have, but still cases that some of them have led to hospitalization, to being in intensive care units, and some of them have led to cases of long-term COVID, that it's not a minor issue that has characteristics of chronicity that really jeopardizes the health and well-being of people. So bottom line is, between the lack of use of protection, the mask in public transportation, even in the hospitals, that still lasted until the very last of the phase of the pandemic at the beginning of this year, because of the emergence of new variants, and I will refer to that, and because of the decline in the protection of the immunity, we have witnessed an increase in the number of cases. And this is something that we need to take into account for this fall-winter season, to really be protected and be ready to have the least possible number of cases that we could have of COVID-19. I mean, probably for many people, because WHO said this is not anymore an international emergency or a public health emergency of international concern, which doesn't mean it's not anymore a problem or is not anymore a pandemic. But for many people, the pandemic has disappeared. But the pandemic has not ended. At the end of August, there had been almost 770 million of confirmed cases and almost 7 million deaths attributable to SARS-CoV-2 for that period, 3.5 years that COVID-19 pandemic has been ravaging. So this is not a minor thing. We are talking about almost 1 billion people that are confirmed cases by now, and almost 7 million, which is the death toll of a large war. And I think we need to reflect on this. It has been a true global catastrophe that is still present, with many impacts health-wise, but also healthcare-wise, but also in terms of social and economic development, psychological well-being, and mental health. And what it's important is to understand that the virus is still there, continues to circulate, still mutates and produces mutations that are hazardous, and give rise to new threatening variants because of these mutations that are more infectious and, what is more worrisome, more likely to escape to vaccine efficacy. So it's a pandemic that has not ended. I insist, even though it's not anymore an international health emergency, or it's not in that phase stipulated by the international health regulations, when the magnitude and the severity is much higher, that even prevents from traveling or moving or having free movement of people in nations. But still, it's an infection that is not over. It has not become just an endemic disease, and is not simply a bad cold. It can be a much more severe problem. So, we have lowered the guard. Not being in an emergency phase, in a way explains why the world has lowered its guard on this issue. It's not anymore a political problem. It's not anymore a problem that puts pressure in some of the health authorities. And then we tend to neglect and to deny and pretend that the problem is not there anymore. And this means that the political and the health authorities in many countries, and even many specialized international agencies, have insufficiently been addressing the surge, even though there has been an increase in cases and an increase in the demand for outpatient and hospital care due to COVID-19. So we believe that sufficient diagnostic testing should be done, that this is not something that should be abandoned. And also, very important is to conduct the genomic sequencing that will be required to map the penetration of the new variants to really be mapping the risks. But a very important thing is to reconsider the vaccination strategy. And in many ways to redefine the vaccination strategy for this coming autumn-winter that we have started already, and some countries have started redefining this. And this should be discussed more thoroughly, assessed, and made much more public. Because we are finding ourselves in a situation which would not be fully understood if we do not understand this as a phase of rupture of the precarious balance of disease control. And this is happening because of the combination of several factors. New variants that escape to protection of the previous vaccines in particular, a drop in the immune protection conferred by the available vaccines and the natural infection itself, because the humoral immunity particularly drops importantly after a year of the vaccine of the infection, and the abandonment of protective measures like the use of masks in high-risk spaces, social health spaces, public transport, crowds. So there are things that we should try to avoid. This is not just an issue that we should let go. It is necessary to work to avoid unpleasant surprises, especially in the fall and the winter. Because if we do not act with an objective public health criterion that prevents the situation from leading to a wave of increase in the incidence, we may have a growing saturation of primary care and hospitals, perhaps not reaching the proportion of collapse that we reach, fortunately, not reaching it, as we did in the beginning of the pandemic in the year 2020 and 2021, before the vaccine was administered, and we made some more progress to reduce the severity of the disease. But also, it's necessary to avoid the emergence in almost 10% of the infected people of chronic conditions of the so-called long COVID, with significant sequela and growing demands for health and social care. In a country like Spain, where I live now, we consider that we have close to 1 to 1.5 million people affected with long-term COVID. And we have not given to this the necessary attention and importance because it becomes a chronic disabling condition that requires a lot of specialized care and is not limited to the acute respiratory infection of the acute cases of COVID. A little word about the new variants. The new variants that have emerged in the recent weeks, in the last couple of months, are the EG5 and the BA2.86, which add to the presence of the Omicron sub-lineage known as XBB1.5, which has been dominating the infections in many of the countries. The particular thing about these variants is that they have experienced more than 30 mutations that make them more infectious and allow them to produce a situation in which the infection by these variants escapes, at least partially, the protection provided by the vaccines used so far. So the WHO at the end of August, beginning of September, issued an alert that we should be careful about these variants. We should monitor, we should do genetic sequencing, and we should consider that we should increase the protection against the possible infection and or reinfection by these variants. So WHO warning was very clear in pointing out that we should be vigilant, that we must continue reporting the number of confirmed cases. Many countries have simply dropped the reporting, the publishing of statistics about COVID, unfortunately, and that limits our ability to know what is really going on. We must continue to carry out diagnostic tests, and that we must continue with tracing, and also what I said, the genomic sequencing must be intensified to really know what's the degree of penetration of the new variants. But we really believe that this call is not being sufficiently echoed. And perhaps even WHO is not sufficiently assertive in this regard. And certainly other institutions, ECDC, the CDC in Atlanta for the US, other agencies and health authorities at national level are not sufficiently echoing the warnings as to alert the health professionals and the healthcare system to be vigilant, not to be in a situation of alarm, but yes, of alert and being careful. And I insist, I am missing seeing greater assertiveness on the part of the politicians, of the health authorities, and even of the health professionals and the media. Well, many of these considerations should lead us to the review of the COVID vaccination strategy for the rest of the year. But in many respects, we have been a bit late with this. We were certainly late because we didn't start these boosters or protection early on, and in the best of the circumstances in countries of North America, Europe, and others that have had access to vaccines, we are beginning since a week ago or 2 weeks ago or so, at least not before October, to vaccinating again, to applying a booster that is particularly directed to protect with respect to the emergence of the new variants. But there is not sufficient noise made about this, not sufficient advocacy, I insist, by the politicians, by the health authorities, by the health professionals, by the media, by NGOs. And I think we need to be more proactive and more assertive with respect to this. I think what we need to consider is that with the new vaccines that have been developed, not the original vaccine, not the bivariant vaccine that protects against the original and the Omicron, but with this, let's say, third formulation of vaccine, particularly of Pfizer and AstraZeneca, also RNA vaccines, or that are directed towards the new variants, the new lineages of Omicron, we can obtain with these vaccine formulations protection against the new variants, and we should consider that this is the way to go, and not just to use large stock of the previous doses in storage that many countries have accumulated. So sometimes because of economic reasons, sometimes because of economic political reasons, countries do not speak clearly. But I mean, what we need is to renew the vaccines with the new formulations to protect people against the new variants, and to apply this new vaccine and to explain this to the population. The situation of the observed spikes and what the increased risk of infection and reinfection should make us think that this new round is necessary with the new formulations of the vaccine that respond to the new variants. And there is a debate whether this should be done for the entire population this autumn and winter, or just for high-risk groups. But what is important is that health authorities should not shy away from this debate. A technical debate that needs to take place to strengthen immunization against this virus that is still present and that is escaping the protection or effectiveness of previously used vaccines. So it is essential to launch a new, hopefully in many cases, combined flu, seasonal flu, influenza, and COVID vaccination campaign, certainly for the over 60 years of age population this fall. We need to get vaccinated with a new dose of COVID, new formulation of the vaccines, plus the new flu to be adequately protected from acute respiratory infections this winter. Given the increasing cases recorded this summer, both in primary care and hospital care, it would be advisable to at least discuss the merit of expanding the administration of the COVID vaccine to the entire population. This has been done by the US. CDC Atlanta has issued a recommendation around the end of August, beginning of September, of vaccinating the entire population with a new dose, a new booster of the vaccine with a new formulation. But many other countries have been reluctant, have just said, well, we will just deal with a high-risk population, quote unquote, which encompasses the over 60 plus the immunosuppressed, plus the people with other pathologies, plus the health workers, plus the people who live in nursing homes or geriatric homes. And when we start adding up, and especially in age societies, we are talking about a considerable size of the population, oftentimes more than a third of the population. And with the risk of having, because of inadequate rates of protection of the younger segments of the population, a segment left unprotected. So this is why CDC went in the direction of the vaccinating the entire population. But so far, practically no country in Europe or elsewhere has gone with this recommendation, and it's only moving. Even the European Center for Diseases Control has recommended only doing it for the over 60 and high-risk groups. But let's remember, a long time has passed since the first rounds of immunization. There is no considerable proportion of the population that did not get boosters with let's say, third dose of the original vaccine, or with a fourth dose of the bivalent vaccine. So the level of adequate protection, especially in the younger population, is low. And the vulnerability of the over 60 is high. And this is what, in many respects, really calls for a more intensified effort for vaccinating. So very important is informing the population. This cannot just be left to the secrecy of the deliberations of the health policy makers or of the health workers. I think if we do not engage the population, particularly with the vaccine hesitancy that has existed, with the reluctance to get vaccinated, with the anti-vaccine movement and how pervasive it is, if we do not do the appropriate information to the population with adequate social and health education, we will not be successful in doing what we need. I already have insisted the virus is still present and mutating. The protection must be renewed, and we must be cautious and protect ourselves and others from the risk of infection or reinfection. Engaging politicians, health authorities, health professionals, the media, and citizens at large. I will just spend a couple of more minutes going beyond this more punctual and review and recommendation to underscore the relevance of vaccination now and the relevance of using adequate protection when we have a resurgence of the infections. I mean, I must say, I use the mask in public transportation and in planes when I travel now. And I use the masks if I go to a hospital or a health center. That's where we have a concentration of higher vulnerability. And I think we need to take into account this and not think that the pandemic is over and not be in denial with respect to the reemergence of infections of the disease. But I just wanted to devote a couple of minutes to reflect with you based on the lessons learned from the pandemic. And there are so many lessons that we should internalize and we don't necessarily internalize. What are the opportunities for improving the pandemic response to this pandemic and to future pandemics? And what are some of the actions that we still can do to be in a better situation for preparedness, responding, and recovering from what this pandemic has produced? Well, some key areas of opportunities that we have for the future. We have relatively poor capacity for pandemic preparedness, contingency plans, stockpiling of human and material resources, and this needs to be done. These requirements were not met at the beginning of this pandemic, and we have all the elements to work more on pandemic preparedness and contingency plans. It's also important to ensure the international health regulation core competencies are present in all countries to be able to respond to epidemic and pandemic situations. When we started this pandemic, 65% of countries in the world did not comply with the mandated core competencies of the international health regulations in 2005. So we need to intensify action to improve these, to improve the epidemiologic surveillance, the capacity of laboratories, the ability to track and trace some of the cases. Well, this is still not adequately developed. At the European level, there are difficulties in defining harmonious policies in health crisis situations. I mean, certainly at global level, but even in a community of nations that supposedly has greater cohesiveness, supposedly, not for everything. Well, having harmonious policies in health crisis is not yet there. Every European country, each European country, defines protective measures without a unified approach. There is quite a discrepancy throughout the pandemic in this. And governance operates with, I mean, particularly global health governance or regional health governance, sometimes national health governance, operates with weaknesses and does not establish coercive measures for those who do not follow the recommendations. I think it's very important that we also revisit many clinical and epidemiologic paradigms on which the recommendations, the initial recommendations were based, because they were obsolete and exceeded by reality. It took some time for us to understand the importance of the use of masks because it was believed that this was not transmissible by aerosols. It took some time to understand that the virus could be transmitted by people infected but being asymptomatic, because we were using the paradigm of influenza where essentially the transmissibility is if you have symptoms. So I think we have to adapt our thinking very rapidly to understand that we were dealing with a new virus, a new type of pathology, a new way of understanding the transmissibility and the protection against it. And this doesn't always let's say, gets the prompt attention with the open mind that it's necessary. Something that also we should improve are the care models of nursing homes that were brought together, that have brought together many people in close proximity, and that, created a huge mortality at the beginning of the pandemic before we had the protection of the vaccine. Because there was an intensified contagion, being a disease that affected vulnerable people with greater severity and with greater transmission in close proximity. But I mean, even if we develop enough protection with the vaccine, we could have another pandemic of another infectious disease, also transmissible by aerosols. And if we continue having the models of high density of interaction of people in nursing homes, we are going to have the same problem that we saw in COVID. We need to take into account the considerable healthcare pressure, both in primary care and hospital care, that results in delay of care for other pathologies that have caused an excessive mortality, not only because of COVID, but because of the collateral damages of COVID, in addition to the pressures of care itself. Something that I think we need to underscore is that equitable access was not uniformly established in all areas. Not all countries had equitable access to treatments, vaccines, diagnostic tests, and the commercial and patent interests were more important during this phase than the public health interest. And I have to say, well, unfortunately, that has subject to the rules of market, something that cannot possibly be exclusively left to the rules of market. The health security has to be done regardless of the ability to pay. And in this case, we're not talking about health services. We are talking about public health measures that are let's say, that are protection, like the vaccines, and that are non-pharmacological interventions, like all the measures to reduce the risk of exposure and transmission. So in many ways, the global health system has failed. It hasn't even had the funding nor the negotiation skills, especially with industry, to make vaccines a global public good. We have observed also, and this is something that we should be worried about, a reluctance towards restrictions by some populist ultra-right political groups favoring everything that involves risks. We need to take into account that there is not only individual positions, but that these are harnessed by political interests of especially populist group, especially of the ultra-right. The psychosocial impact of pandemic fatigue has also to be prevented and mitigated in people, in health professionals, in health policymakers, and even in politicians. And the decisions of the health authorities to deal with the pandemic need to be much more unified and not subject to the political partisan confrontation that oftentimes subjects something that needs to have scientific and technical deliberations for governmental responses rather than political or ideological ones. No? The attention to recommendations have been depending too much on the political logic of the moment, and in a pandemic like this and in an issue of this nature, we cannot just be subject to the political logic of where the wind blows at the moment. So I finish with some reflections on the proposed actions for improving pandemic response. Plan at all levels, global, European, country, regional, local, to be able to respond appropriately to health emergencies, contingency planning, preparedness for future pandemics. Review the national legal frameworks so we have clear actions of the national health systems as a whole. The central administration and the autonomic communities or the federal states or the regions, leaving no gaps that can be filled by the ineffectiveness or polarization. Transforming the European legal systems to provide competencies to the Commission to define binding and unified policies in situations of health crisis. And I think this time the Commission showed that it had very little muscle because the health matters are of the sovereignty of the nation states, of the member states. And unfortunately, this dilutes the possibility of having a common response. Have no disparity of positions and reactions among the different governments, especially for blocks of communities of nations such as the European Commission, as an example. Very important is to learn the lesson of increasing and improving the level of public health spending. It's underfunded public health action and understaffed, and this needs to receive greater attention. Develop strategic reserve capacities. I think it was clearly shown that we needed to have stockpiling of respiratory medicines, specific tests, diagnostic tests, other supplies to be able to respond swiftly to the emergence of a pandemic. We cannot have everything. We cannot have a vaccine that doesn't exist or diagnostic tests that do not exist. But as soon as this is developed, I think creating the strategic reserve capacity and having a strategic reserve capacity for the generic needs is very important. As well as I said, increasing the number of health workers in the public health system. We need to have new international frameworks that involve the cession of sovereignty to act in emergency cases and establish penalties for non-compliance with the international health regulations. Hopefully, the new pandemic treaty that is under negotiation will go in this direction, but still, I think we are far from there. I think, as I said, the European Union needs a unified European policy on public health, especially for health emergencies. And similarly, in countries that are not unified, there should be a unified national policy to deal with special crisis situations. And have more anticipatory capacity, more legal instruments of binding nature, and not just recommendations, more pandemic preparedness, better preparedness, more contingency plans, and more and better governance. The last one is, well, I think it's very important to understand the provisional nature of scientific knowledge and review it to adapt measures in a consistent, rapid, and effective manner, review the geriatric healthcare model and care model at large to have less population density in social and health centers, and further the measures necessary to protect the residents, the workers, and the visitors. Have very specific business continuity plans and specific plans for hospital and primary care. Create pandemic circuits and non-pandemic circuits to not let the presence of a health emergency set aside all the regular and normal care of the population. The implementation of the non-pharmacological measure needs to be accompanied by complementary measures towards the most vulnerable. I think we need to understand that we succeeded to control the most critical phase of the second part of 21 and beginning of 22 because we applied the extensive vaccination that protected, and also because we applied non-pharmacological measures, particularly the use of the mask in crowded situations, in closed, non-well-ventilated areas, and in public transportation and health centers. In summary, we need to act as a global society to put everything at the disposal of the health emergency, vaccines, releasing patents, create more flexible intellectual property conditions, and favor technology transfers. Build more and better elements of social pedagogy, of social communication, and make these guide and inform and accompany citizens in situations of health crisis. So I will stop there. I will be more than happy to entertain comments or questions and try to respond to your interests and concerns.
Thank you very much, Dr. Lopez Acuña. This was quite exhaustive, complex topic, and again, not really good news, but certainly some precisions that are very important. I have two sets of questions. Those that are related with the vaccination itself, the vaccine and the vaccination campaigns themselves, more specifically, and those that are related to the policy issues, what to do in the current situation, and what sort of measures could be envisaged. So if I may, I would like to start regrouping the questions regarding the vaccines and the vaccination itself first, and then we can move to the policy issues, the more political level, macro level, if I may.
Yes.
So regarding the vaccines and vaccination campaigns, you said you gave us a lot of information. There are some issues that I would like to clarify with you that are related to the questions that were raised. One, for instance, refers to the stock of available vaccines in storage. You said that there are stocks, but are these stocks useful as compared to the new variants of the virus? And are they available, or is the storage enough as compared to the needs of all countries? Of course, I'm thinking about developing countries and poor countries in the first place. I have several other questions regarding the vaccine and vaccination. Do you want me to regroup all of them in one single package?
If you want, yes, yes.
Okay, so that was one. Then a technical question regarding the new risks of contagions are also affecting mainly older people, or is it more a sort of general risk, general threat that is coming? What is the name of this third generation of new vaccines, and how different are these new vaccines as compared to those that we had before, regarding particularly the boosters? What are the main differences? Are we contemplating, or will we have soon, as was announced something like 2-3 years ago, one single vaccines for the flu and the COVID combined in one single shot? So mainly these are the technical questions regarding the vaccines and the vaccination campaigns, if I can take them all together.
Well, let me go very, very succinctly to answer this. First, the resurgence of COVID has not been limited to the older people. It has been affected all ages. Actually, there were plenty of cases among children. So the reinfection is taking place across the age spectrum. What happens is, of course, the greater vulnerability and the greater severity takes place in older people or in people with comorbidities or other pathologies. Second is, what makes sense is to put the new vaccines that are let's say, the third generation, that protects against the more recent variants that are having a greater tendency to escape to the previous vaccines. So last year we had in October the approval and the development of the vaccine that was useful against the original and against the Omicron, the original variants and the Omicron. That was important. It was useful. Many of us got it. I got it, certainly. But Now we have had the approval by the European Medicaments Agency and the Food and Drug Administration, and the recommendation by CDC in the US and the ECDC in Europe of the new formulation of the vaccine, both manufactured by Pfizer and by AstraZeneca, that are protecting against the new variants that have been present more recently. I mean, the unfortunate situation is that we are with a type of vaccine that is not lifelong protecting, that is not sterilizing vaccine. And in many respects, we need to understand, and Anthony Fauci, the advisor of the White House for the COVID and many other infectious diseases, said it at the middle of the pandemic. We need to get used to the idea that this is going to be an annual vaccine, like the flu vaccine, that will have to change with the different emergence of variants, depending on the situation that happens. So the vaccine that the public health systems of some countries, is the case of Spain, has started applying, is not what was in the warehouses of, let's say, strategic doses of the second generation of vaccine, but they are applying the third generation. What the US is applying is the third generation of vaccine. So there is very little point in using the previous vaccine if it's not going to protect us adequately against the new emergent variants. Another discussion is, and this is a discussion about solidarity, development, ethics, is if there was going to be this surplus of vaccines that would not be useful anymore, why didn't we make the necessary to make them more available to countries that have difficulties in access? I mean, this has been the story all along, where the international mechanisms to secure access to the vaccine has been insufficient in many respects. Well, the thing is that we need to think in terms of strategic reserves. We have reserves up to the moment where that is useful, but if there is an emergence of a new one that is going to protect us, well, we need to move into the new one. I think many countries are not making so much noise about doing it because of the economic implication of purchasing of the vaccine. Actually, even European Union with its joint procurement, it's rather silent with respect to the vaccine. I mean, the Ministry of Health here in Spain had to state clearly that they were not going to apply the old vaccines or even a new vaccine approved by the European Medicaments Agency from Spain that was not protecting to the new variants, but that it's putting the new vaccine. But I would say all along, we have had too much silence from the health authorities with respect to this. And I think the public deserves greater veracity in this and clear facts. I think we all need to be said, well, you need to get protected with the new vaccine. And the health systems need to apply. I mean, when you have a national health system with universal access where publicly financed and the decisions are made centrally, it's easier to implement swiftly the application of a new vaccine, because it's not an issue of what is there or in the market, but it's what comes to the system and is applied. This is what is happening in Spain. It's happening in other countries as well, of course, that have similar national health systems. In the US, the issue is more private because there is no coverage of the vaccine, unfortunately, by public, as it was in the beginning, by public financing. But the vaccine that is being applied is the third generation. So I think it will vary case by case in terms of the countries, but bottom line is what is necessary is the new one and what will add the protection. I think in many countries, what it's happening is that they are giving you a shot in one arm, the flu, and then a shot in the other arm, the COVID. It's not a combined vaccine, but it's not a problem. It doesn't have any secondary effects. Actually, it rationalizes the effort of vaccinating in one single episode for both diseases. So I think I completed the answers to your questions.
Yes, thank you very much. And indeed, you also opened the window to the policy issues that are related to what you said, related to your presentation. And I have five questions at that political macro global level.
Yeah.
The first one concerned the financing of the campaigns, the vaccination, and the overall effort that was put in place at the beginning of the pandemic. Mm-hmm. Is there a sort of fatigue of spending resources on that topic that could also be, at least partially, an explanation of lowering the guard? I mean, people and governments are probably already tired of talking about this topic, and therefore, politically speaking, it's not as attractive as it was at the beginning of the pandemic 4 years ago. And in this sense, regarding the risk of the fatigue of spending, I hope, and probably you hint in that sense, that the research regarding the new variants, so the need to update the vaccine, the research is still ongoing. The network of experts working on COVID and related issues are still in place, if I understand you correctly, even if they're not in the headlines. So that's the first question. The second one would concern what to do concretely to draw the attention of the policymakers regarding the new threats, and try to explain to them that this issue needs to be put at the top of the agenda again, unfortunately. The third question regarding the risk of contagions between conflict and non-conflict areas at the world level, if there is a risk or not, or if conflict or non-conflict area just face the same risk or threat of having contagions spread all over the population. The fourth question, and I think it is a very important one, concerns the coercive measures that you mentioned in one of your slides, coercive measures for the countries, the governments that do not follow the recommendations, do not comply with the health regulations, and therefore raise risks at the global level. And this, I think, is closely related to the ongoing negotiation at the WHO on a new pandemic treaty. And you mentioned also in one of your slides the negotiation skills that are needed today to address these market approaches that are still prevailing in the overall management of the global health issues and vaccinations. And as far as I know, the new pandemic treaty that the WHO is still more or less stuck in terms of the negotiation itself, and stuck with the usual issue of the intellectual property rights regarding not only the vaccines, but also what is related, the overall technology transfer that are related to that. And for me, the negotiation skills that are missing is that it's not a WHO negotiation, this is a WTO negotiations, where at the WHO you have doctors, specialists on global health policies that are obliged to negotiate on trade and related intellectual property issues, which is not their domain. These are WTO issues. How to solve that problem, I think, is not clear yet.
Yes, we have so many macro issues that we need to address and to deal with, and it's not simple. And well, first of all, I think, unfortunately, governments, people, and health authorities are lowering the guard because they are not scared anymore. But they may not see what the risks are of having A, another pandemic, but B, just the appearance of a variant that can escape the protection of the vaccines. I think a lot of advocacy by the health sector and by the WHO and other international organizations is necessary to ensure that the governments keep the guard up. That, I mean, we are not going to have the same level of receptivity and reaction than at the beginning of the pandemic, when everything was scaring everybody. But I think this is where, how could I say, adulterating situations do not help. We cannot sweet talk about risks that are there. We cannot banalize or underestimate the risk. And we need to insist on the importance of developing global public goods and the mechanisms for this, specifically and particularly for pandemic threats and situations. This requires new frameworks with WTO, I agree, fully. Specifically for these types of situations, new frameworks for technology transfer and pricing. I think if something showed clearly and evidently, it was the failure of the mechanisms, even the COVAX mechanism created to redress the failures of the market, quote unquote, because we are not having the necessary ingredients for a global health security. We need global public goods for a global health security. So in this sense, the worst scenario that we can have is that we think that all of this is over, that there will not be any more pandemics, and that we do not invest in public health capacities, in research, in preparedness, in contingency planning, because this pandemic has shown that by not doing it, we have permitted to have a situation where we have had a huge death toll that could have been reduced substantially should we have had some of this. Granted, it's a new virus, was a new disease, we didn't have at the beginning the vaccine, but there were things where we could have been better prepared and act more decisively. And I think those lessons are the ones that we need to take stock from.
Thank you very much. Just to clarify, the questions that are raised were a sort of compilation and cocktail of the questions raised by several participants here. In particular, just to mention David, Mohan, and Alejandro's questions. So I just tried to organize them in a way that could facilitate your task in explaining
Thank you.
more and elaborating the presentation. I do not have, I think, if I am looking at it correctly, I do not have new questions or new comments on so far, but I don't know if I will give the floor to Alejandro for some maybe concluding remarks, or unless Dr. Lopez Acuña has some other conclusions or further clarifications.
Yeah, no.
Over to you, Alejandro.
Thank you very much.
Thank you very much, Manuela. Thank you very much, of course, you, Dr. Lopez Acuña. This was really a very informative session. A couple of participants just left, and they said that they were like in a roller coaster. I felt the same, because at the beginning of your presentation, I was reassured, and I knew that we know now things that we didn't know when the pandemic arose. But then at the end of the day, you highlighted the risks and of mismanagement and not assessing and facing the risk and doing a risk management adequate in the future, and we can come back into difficult situations. Thank you very much for a really very clear diagnosis based on facts and also analyzing those facts for us. And you didn't stop just in the analysis. You made recommendations. Thank you very much for that. You made recommendations at the policy and the strategy level, at the global level, but also I found that they were really very useful at the individual level. And in the same way that we usually say that we have to think globally and act locally. Now I think that we have to think community, but act individually. The fact that yourself, the expert, you're using a mask when traveling public transportation, really give me a hint. I should do that, and I will encourage my wife and family to do that. If the experts are doing it, I think it would be sensible to do it. So thank you very much. I'm sure that there will be many views of this in our YouTube channel, and we are extremely grateful with you, Dr. Lopez Acuña, for this, which is the fourth participation. I hope that we'll be able in the future to have you possibly in another topic, and I hope that the policymakers will follow your recommendations so that this in time becomes something like a lower risk for all. Thank you very much, and thank you very much for all the participants.
Thank you very much, Alejandro.
See you in our next Greytalk in November 6th on financing for development, which possibly will include also financing for health issues. Thank you very much. Have a great evening, morning, or afternoon, whatever you are in the world. Thank you very much, Daniel.
Bye.